Hello, good morning, everyone, wherever you are in the world. So if you are in APAC region or in EMEA, we are back to our first ASP Summit 2025 webinar series. My name is Jaime Alves. I'm the ASP Global Head Professional Education, and it's my big pleasure to kick off today this new series of program featuring 6 webinars under this topic: Shine On, Flexible Endoscope Reprocessing. Before we get introduced to today webinar speaker, I just want to let you know that you're gonna have, as always, these 6 webinars. The next one will be sharing with you at the end of this webinar session, but you can also stick to the rest of the schedule that we have planned with some hot topics on regards flexible endoscope reprocessing that we're pretty sure that you would like to know more about it. So before we get introduced to our moderator and host for today, I would like to share with you some housekeeping tips and rules for you to have a great webinar experience. First, please make sure you switch off any non-essential applications on your device, which may be taking away from you the internet bandwidth, like the Outlook or any others. If by any chance during the webinar you face any kind of disturbance on sound or image, please refresh your browser window or close and log in again. Today's webinar will start with a 40 minutes presentation followed by 10 minutes Q&A. We will conclude the webinar with the key take-home messages as always, and we will introduce you to the next webinar speaker and topic. This webinar will be finished in 1 hour for respect everybody's agenda. If you have any questions for the presenter that are not answered during the presentation, please make sure you type them on your chat box that you find on the right of your screen. If you are with a mobile device, you will be found them on the bottom part of the screen. In order to make the presentation part of this webinar more interactive, you will also have during this webinar several live polls where we invite you to answer the speaker questions. You will have few time to do that, so please stay tuned for those questions. Besides, this webinar series will be having simultaneous translation. Just follow the steps that you find here. Scan the QR code, please. Install Interprefy, that is the application that we'll be using, and then select your audio language that you will find on your screen. You can connect your phone with your headsets or just put it on speaker to listen to the translation, and you also can see the captions on the screen of your mobile. So in order for you to have a better experience, we invite you to maybe to see the webinar on the PC and to get your simultaneous translation on your phone, no matter if it is by having the sound on your earpods or the captions on your screen. And by the way, you can select to have it the audio in one language and the captions in the other one. So a lot of flexibility. Don't forget, just scan the QR code. So one last point, this webinar will be recorded. So the link with the replay will be sent to the resistance early next week, okay? So now it's my big pleasure to introduce our moderator for today, Dr. Carlos Paulos, that is also the scientific director for this ASP Summit 2025 webinar series. Those that joined previous webinars already know him. Dr. Carlos, welcome again to our ASP Summit and kicking off this 2025 webinar series. Thanks for joining us today, and I will hand over now to you.
Well, hello everyone. It's a big pleasure to be with you again. For the ones that already have attended the previous series, so welcome again. Sorry, I think there was a problem with the micro. I was welcoming everybody, the new colleagues that are attending for the first time, and the others that have been attending for the other series since 2020. So it's my big pleasure to be here again. I also want to thank ASP Summit for this possibility of taking part of this wonderful experience, and we want to make you shine on the flexible endoscope reprocessing this year. So just to give you a brief summary of who you are. So most of you are nurses or some people from the decontamination systems and services, and also some physicians, which is always very, very nice. So most of you came from the sterile service departments and from acute hospitals. And most of you have more than 10 years of experience. And the most amazing thing is that we have people from all the regions, mostly from Middle East, as always, and also from Europe in this precise moment, for Portugal. And well, welcome all. You are all welcome in this series. Some of you are attending it on live, but probably most of you will attend it after, because the time schedule is not so well fit for the job that we need to do. So welcome. So can you move on for the next slide? So it's my big pleasure to have you to present you Mr. David Bellamy, which is going to talk about what's new on flexible endoscopes reprocessing guidelines. And well, David Bellamy is a very important person. So he has been working more than 20 years on this field, and now David is, since a few years ago, the vice president of the World Federation of Hospital Sterilization Sciences, Sterilization, and he also works at the sterilizing service department at NSW Health in Australia, and where he is currently the manager. So David is committed to excellence on sterilization, on infection and control education, and he has a lot of positions on this field, also in Australia. And so it's a big pleasure to count on you with your expertise. And I hand over to you for your talk that we are sure that will be a great one. Thank you, David, for being with us.
Thank you, Dr. Powers, for the introduction, and thank you, ASP Summit, for the invitation. And what a privilege to kick off this webinar series. So I'm generally looking forward to hearing from the experts throughout the rest of the series. Sorry, just had to share my screen there. So yeah, I'm generally looking forward to the insights from the other experts that will be sharing their series throughout the series, and their valuable insights they'll be sharing. So today's more about laying the foundation for the series, and by highlighting why endoscope reprocessing is such a critical aspect of infection prevention. I'll be comparing the key standards and guidelines that are currently available to us, and touching on some newly released recommendations, and of course the upcoming new ISO guideline that is currently under development. By pulling all this information together from the standards and guidelines that I'll be referencing, I hope to provide some useful reference points, one that kind of encourages you to reflect on your own practices and consider where updates or improvements might be made. As we all know, endoscope reprocessing is a global topic, and the more we share our knowledge and collaborate, the greater the impact we can have on patient safety and effectiveness. So the first topic will be enhanced cleaning and pre-cleaning protocols. And as James said earlier, we're going to start off by having some polls just to gather information on what other countries are doing and what the practices are. So this is our poll that we'll have up for about 30 seconds. If you can click and just tick on what your current practices are, even if you think what they should be, just so we can gather that information there. So, and no one likes silence. So, and especially me, because I'm kind of talking to myself, but I know there's so many of you out there. So what we'll do is we'll end it there at 35 seconds and have a look. But with the results, as you can see, so 89% of us are either thinking that we should do it immediately after the procedure at point of use, or we already are doing. So, yeah. All right. And then there's some other ones there where we have that do it within 2 hours or upon arrival at the reprocessing room. So getting into it, let's get started. Okay. So while we don't have real precise up-to-date minute information or the global statistics on HAIs that come from contaminated endoscopes, it's difficult to find. There are several studies that indicate significant risks and impacts, and studies have shown that, and one of the studies that have shown high-income countries have a prevalence of HAIs of approximately 3 to 12%, while in low and middle income countries, that can range from 5 to 19%. And some of those studies, definitely that are out there, have shown that there is substantial percentage of HIAs that come from related to contaminated scopes. So just highlighting a few examples of why we do what we do and show why it is important. So within this webinar, I'll give a few documented examples of breaches. And the first one is just a recent one, and it was actually one within Australia where we were sent an advisory that there was potential risk of patient infection when the reprocessing procedure was not performed as instruction. And this actually led to 120 serious injuries and actually 1 death due to the infection. So this is showing why it's a foundation role that cleaning is the cornerstone to prevention infection, and particularly with the context of endoscope reprocessing. It's kind of it's the essential first step in decontamination and, of course, sterilisation. And the primary objective is to remove organic and inorganic soils, such as blood, tissue, and protein matter, that can be inhibited in the action of both chemical disinfectants and sterilants. So, for residual contamination remains, subsequent disinfection and sterilisation processes are compromised and can lead to potentially leading to clinical failure, like we just showed with the outbreak. Also, one of the most critical risks associated with inadequate cleaning is biofilm development. And biofilms can begin to form within minutes on moist contaminated surfaces. Once established, they exhibit significant resistance to chemicals, including high-level disinfectants and sterilants. So the resistance is due to the polymetric substance matrix, which protects embedded microorganisms and can harbour pathogens for extended periods. So effective cleaning processes are significantly validated to result in a log reduction of microbial load and thereby significantly lowering bioburden. So reducing bioburden is theoretically a benefit, but it also has a direct measurable impact on the efficiency of high-level disinfection and, of course, sterilisation. And it is proven in many studies to reduce the risk of hospital healthcare-associated infections. Just a quick another example of a hepatitis C outbreak that was found in flexible endoscopes used for colonoscopes. And they found that they were improperly being cleaned. So this led to the transmission of Hep C virus among multiple patients. And then looking at this study, the lessons that they learned were that they needed to improve the importance of point of use cleaning, highlighting that the importance of thorough manual cleaning prior to disinfection and of course the implementation of standardized protocols and staff training, as well as regular audits of the process and procedures to ensure compliance. And that will be highlighted throughout the rest of this webinar. So to quote a fundamental principle in infection prevention, as we all know, if it's not clean, high-level disinfection and/or sterilization cannot be achieved. And this is what underscores the cleaning is not an option. It's not negotiable. It's a prerequisite to achieve microbiological safety. So what I've kind of done here is on this slide, I put together as best I could a comparative summary of endoscope pre-cleaning at point of use guidelines based on the key standards and guidelines that I'll be referencing. And they are ISO 15883-4, the GENSA guidelines that were released in 2025, the AAMI ST91 that was from 2021, and AS 5369, which was released in 2023. So the focus is on pre-cleaning at the point of use, which is the first critical step in the reprocessing of flexible endoscopes. And yes, it should be done within the procedure room, as we pointed out in the poll that most of us are doing. And some key similarities of all four standards have emphasised the urgency of pre-cleaning to prevent biofilm and soil fixation. So I looked at the aspect of time-specific guidance, the detail level for bedside practice, and compliance of the role and biofilm emphasis role. So the comparison kind of reveals the notable differences in both GENSA and AS 5369, where it's recommending pre-cleaning within 15 minutes, which this is aligning with international best practices. And the ST91, however, allows up to 30 minutes, while ISO 15883-4 provides only a general timing and guidance. In terms of bedside practice, the detail in the ST91 stands out with very high detail, followed by GENSA and AS 5369, both offering high levels, where ISO remains a more generalised guidance. And they all emphasise biofilm prevention. And with ST91, you can see they're providing the strongest focus, followed closely by GENSA and AS 5369, and a moderate emphasis in ISO. So in summary with these, all four prompt and look at effective pre-cleaning at the point of use. Universally, it looks like it's recognised as essential to prevent the biofilm formation, ensuring patient safety and protect the integrity of endoscopes, while ISO 15883 provides kind of the foundation for how AERs are used, and the others offer a more detailed, actionable guidance with stricter timeframes and clearer accountability for bedside practice. Okay. Now just looking at the good old manual versus automatic. So this involves a series of critical steps, of course, manual cleaning, automated processing. It's also increasing that we're also looking at sterilisation and of course the validation that forms part of this. So I'm just going to highlight how each of these components is guided by these leading standards and guidelines, just to ensure process integrity. So while manual cleaning remains essential for the complex high-risk instruments, it cannot always be visually inspected but all reprocessed by a machine. So standards like the ST91 and GENSA emphasize manual brushing underwater to prevent the aerosolization of contaminated particles, and it's a technique particularly relevant in endoscopy. Also talking a bit later on about tools, but using soft bristled brushes to avoid causing any damage to scopes, and the use of removing debris, also for internal channels and lumens. There's also followed by a thorough rinse after an enzymatic soaking to ensure detergent residue is loosened and soils are removed also. There are still many discussions about the manual step process. There is talks about that being automated, and that I still feel that manual is a better option, but as technology advances, we will get more automation happening there. But all the standards agree that it must occur prior to high-level disinfection reprocessing and must be performed by a trained personnel under controlled conditions. So now looking a bit at washer disinfectors, and as these are increasingly being utilised, This is what forms ISO 15883-4. And that is for how automatic washer disinfectors for endoscopes should perform as well. So these machines provide validated, reproducible and time-efficient processes, which typically include pre-rinse, detergent wash, thermal disinfection, and they're starting to include a drying phase. Where standards like ST91 require that washer disinfectors be regularly challenged with test soils, and staff must verify that their cycles meet temperature time specifications. AS 5369 mandates that all automatic equipment used in Australian healthcare settings must be commissioned, validated and routinely monitored with documentation available for auditing, and this is through IQ, OQ and PQ, which is installation qualification, operational qualification and performance qualification, which is normally done annually. As we know, endoscopes are becoming increasingly complex and the microbial resistance continues to rise. So sterilisation is also becoming more critical in reprocessing pathway. So traditionally, ethylene oxide was about the only way that we could sterilise these flexible endoscopes. Now we've got, as well as for formaldehyde gas sterilisation, and they have been the preferred and validated methods for achieving sterility in heat-sensitive instruments. However, with the advancements of technology, more manufacturers are now validating devices for alternative low-temperature sterilisation methods, such as hydrogen peroxide plasma. And this is allowing for a faster turnaround, a less toxic, and importantly, of having it available at a shorter time frame. Also, with a sterile cycle, manufacturers of washer disinfectors are introducing advanced cycles. They're claiming sterility, so that's reaching a sterility assurance level of 10 to the power of 6, where this is aligned with the standard benchmark for sterilisation and a log 6 reduction in microbial load. So these developments are reflecting a growing shift towards integrated, validated and efficient sterilisation solutions in response to evolving clinical demands, and of course, infection prevention. So with ST91 and AS 5369, they both stress the importance of following device-specific IFUs as well. So, and that's to select the correct sterilisation method, packaging, and all the rest of it. And there are companies and manufacturers now that are validating their flexible endoscopes through low temperature hydrogen peroxide, and as well as through the AERs. So these standards also require that, of course, thorough drying before sterilisation, as residual moisture can hinder the sterilant penetration and promote microbial survival in the drying phase. So also purging of air and having drying cycles within these AERs are also becoming more popular and advancing. So just another more emerging trend as well is that there's a new option in the guidelines for where an endoscope manufacturer has developed a novel approach to endoscope reprocessing. So the system provides endoscope inspection, they do the microbiological testing, they do the high-level disinfection, and they sterilise with ethylene oxide. These endoscopes are then dispatched to endoscopy units throughout the country in sealed bags, and they are sterile bags. And then they go with the microbiological reports and ready for immediate patient use. They also claim that when stored in their sterile bags, the endoscopes have a shelf life of 18 months. So this system has potential advantages for patients in endoscopy units, including helping to improve access to endoscopy procedures in regional and remote areas, especially here in Australia. So looking at the stages, and each stage of the reprocessing, of course, is detailed by standards, and it's designed to protect the patients and insurance compliance. And by integrating best practices from standards and guidelines like these, we create a system that is evidence-based, validated, traceable, and of course, supporting both infection prevention and regulatory excellence. So now a little look at the tools of the trade, as you can say. So effective reprocessing begins with selecting and having the right tools and chemicals and using them in a way that aligns with both standards and, of course, manufacturer's IFU. So looking at how these standards and guidelines guide our practices in this area to ensure safe and thorough cleaning. Enzymatic detergents are increasingly being used as the preferred agent in breaking down the organic soils and proteins and fats. And according to GENSA and ST91, detergent selection should also be based on the device type, level of contamination, and whether protein or fat breakdown is actually a priority. So while highlighting the importance of following both device and chemical manufacturer IFUs, not only for detergent choice, but also for clinical parameters such as dilution, temperature, and contact time. So improper detergent use, either being too strong, too weak, or incorrect temperature, can definitely compromise the outcomes or damage our delicate endoscopes. So with physical tools also playing in a part of the process, so you have to make sure they match precisely and are designed to the device. And it also says that appropriate size of brushes for internal lumens and intricate grooves are also that they're non-metallic scrapers and soft sponges for fragile or coated surface. So this is also aligning with ISO 15883, which states that manual cleaning tools must not compromise device integrity or create risks. And then going into what's new in this kind of field, and that's the new and emerging technology of borescope visual inspection devices. So they are now being strongly recommended and supported by the standards, especially for complex flexible endoscopes. And these tools enable internal inspection of the channels after cleaning to detect retained soil, damage, or biofilm formation. So issues that may not be visible during routine reprocessing can be seen by these borescopes. And as a bit of a best practice tip, there is also a common point across all the standards that I looked at, and it's strict adherence to the detergent's instructions for use. So ensuring that correct dilution ratios, optimal temperature range, and minimal contact time for enzymatic action. So failing to follow these parameters can lead to the protein fixation or again degrading the device surfaces. So in summary, the right tools and chemicals must be used correctly and fully aligned with the manufacturer's instructions. And adding things like borescope to your practices can also enhance the overall process. So our next topic will be drying and storage requirements. So again, I think, yeah. So we'll be going into another poll, and just to find out what everybody's doing, again, gathering the information. So how long can a reprocessed flexible endoscope be stored before it must be reprocessed again, without use, of course, in your country? So again, there's 12 hours, 24 hours, depending on the drying cabinet validation or following the manufacturer's IFU and facility policy or national standards. So a couple of more seconds to get everybody in. Okay, I think I can end the poll now. And so we had two that were close and sharing. So there's the results there. So 33 of us, or 33%, depends on drying cabinet validation, and 43% follow manufacturer IFU, facility policy, or national standards. So, I agree with our standards do state here that it depends on cabinet validation. So yeah, so of course depends where you are and what your national standards are. So the importance of proper drying, and it hasn't played a huge part in the past, but it's actually becoming a huge player and very important when it comes to endoscope reprocessing. So Let's talk about the most underestimated but critical step in the reprocessing cycle, I feel. So according to ISO 15883, drying is not optional. It's an essential component, and it should be a validated part of the decontamination process. ST91, GENSA, and 5369 all reinforce the same kind of principle that if it's not dry, it's not going to be safe. So with reduced residual moisture, it's not just an inconvenience, but it's definitely a biological hazard. Studies, and many studies, have demonstrated that moisture left inside channels on surfaces can 100% support microbial growth, even after high-level disinfection or sterilisation. And this includes bacteria like Pseudomonas, which can persist in damp conditions very nicely. So ST91 specifically cites residual moisture as a contributor to recontamination and failure of microbial surveillance programs. So proper drying definitely does prevent cross-contamination during transport and storage. And also, again, if one device remains wet, it can contaminate the surrounding scopes, so the drying cabinet, or even hands and gloves of the staff that are handling these scopes. In addition to infection control, moisture promotes corrosion, especially in fine channels or delicate metals that are used in endoscopes. So for each standard, I'll just do a quick brief overview of what each standard says. ISO 15883 says drying is part of the validated cleaning and disinfection process. It must use filter or medical grade air for internal lumens. GENSA specifies that drying must occur immediately after reprocessing using a validated drying cabinet, and such as those compliant with ISO 16442. ST91 calls out for forced air drying of channels for no less than 10 minutes with routine internal boroscope inspections as well to detect any retained moisture or residue. And then AS 5369 aligns with ISO and requires facilities to monitor, document, and validate the drying procedures, particularly for high-risk semi-critical devices. And just giving another real-world example, and this comes from a hospital with a Pseudomonas outbreak that was actually located in a healthcare facility in Europe. And they discovered that their bronchoscopes were contaminated due to insufficient drying after the disinfection, which caused severe respiratory infections in patients. So again, looking at that study and the lessons that they learned and what they need to improve was ensuring complete drying of internal channels before storage, adoption of automated drying systems in reprocessing workflows, and of course, routine micro-testing of the reprocessed devices. So in summary, if drying is not a finishing touch, it's a core infection prevention step. And this message remains consistent. If it's not dry, it's not safe. And of course, proper drying also protects patients, preserves equipment, and supports compliance with international standards. Now, different drying techniques. So as drying is no longer a secondary task, it's a critical component of a validated reprocessing cycle. So whether manual or mechanical, the goal is the same: remove all residual moisture, prevent microgrowth, and ensure it's stored safely. So air drying is often used for the delicate and heat-sensitive instruments, especially where mechanical options are not feasible. However, ISO 15883 warns that passive air drying must occur in controlled, clean environment and free for airborne contaminants. So that said, the method can be slow and inconsistent, particularly for internal lumens and flexible channels. So as a result of that, both ST91 and GENSA emphasize that passive drying alone is not suitable for high risk or reusable invasive medical devices. Now, as we're moving forward, the mechanical drying are now providing more control and, of course, a validated approach. So with the washer disinfectors that have inbuilt drying cycles with forced air, that can also be coupled with HEPA filtration, and there have been studies that have shown significant reduces with the risk of moisture retention before going into the drying cabinets. So once they go into the drying cabinets, we're trying to make sure that we get a uniform drying across external and internal surfaces, which is significantly reducing drying time and risk of residual moisture. So again, one of the elements and new emerging kind of things is and gaining more attention is the HEPA filtration air during the drying cycle. Both ISO 15883 and ST91 highlight the importance of using clean filtered air, especially when drying the internal channels. And of course, this not only improves the efficacy of drying, but also helps minimize airborne contaminants. GENSA recommends HEPA filtered drying cabinets that are compliant with ISO 16442 as well that we talked about. But I'd just like to highlight another emerging new technology in this space, and it's the drying and storage that's being offered. It's a system that uses a drying component so it's a device that has laminar airflow followed by a turbulent flow of heated air to dry the endoscope channels. Once that's dry, the instrument is then stored in a single-use instrument bag. Then this device creates a plasma containing a few parts per million of ozone molecules, and this is then generated inside the device, and then it's insulated into the bag. So with this system, it states that it's got a shelf life of 31 days, and it can be, as it's sealed, it can also be used for transportation, as long as the temperature and humidity is maintained. So this is a new approach different to drying cabinets, but it's using a bag system that has plasma that's inserted into it. So kind of in summary, drying should never be an afterthought. It must be deliberate, documented and validated. And also with best practice being the use, of course, of automated validated systems. So looking at the drying standards and compliance that we have to adhere to now. So as it's kind of now equally a critical stage in the reprocessing cycle, improperly stored scopes are at risk of recontamination. And of course, being into environmental exposure, moisture buildup, and even it can pretty much make the disinfection phase pointless if it's been recontaminated. So they're now defining kind of the environment and physical conditions that are also required for compliant and safe storage of flexible endoscopes. So looking at the recommendations, so storing scopes in a clean, dry, well-ventilated cabinet, ideally those compliant with ISO 16442. And these cabinets are designed specifically to maintain controlled airflow, temperature, and the humidity with these cabinets. Also looking at 53 and 69 and GENSA, and they also emphasise that drying should occur without delay post-processing, temperature must remain stable, and also using HEPA filtration. So as we kind of move forward, and then we're getting into maintaining the integrity. So flexible scopes that may be stored unwrapped in drying cabinets, provided they are completely dry and used within their validated hang time. If stored outside, such systems like with sterile packaging or protective sheath must be used to prevent contamination. And this is kind of particularly highlighted, so there's good references in ST91 around this, if that's what you're doing. And also GENSA and 5369 caution against any packaging or storing that may restrict airflow or of course trap moisture. So lastly, how scopes are physically stored matters just as much. According to standards and guidelines, channels must remain open during storage. Caps and plugs must not be blocked for the airflow. Things like shelving should be non-permeable, smooth, easy to clean, as per the manufacturer's instructions. Scopes, of course, must not touch the floor, walls, and must have sufficient space to prevent contact between devices. And of course, some facilities may use the scope transport or storage cassettes to ensure integrity between point of use and storage, which is supported, but you also may need to make sure there is some thorough cleaning that goes with these cassettes. So in conclusion, storage is no longer just about putting the scope away. It's kind of more about preserving the integrity of the entire processing effort, using HEPA filtration, proper hanging techniques and documentation documented hang time all play a part of this. So going into handling, transport and expiry control, and looking at, so handling and transport practices are often our last link in the reprocessing chain. But any breach in this phase can completely undermine all the other phases, what we've just done. It's also going to compromise the integrity, of course. So the standards and guidelines have now started to clearly define expectations to ensure safe transport, stock rotation and expiry management of the reprocessed endoscopes. And when looking at transportation, so 15883 and ST91 both mandate that the reprocessed endoscopes must be transported in clean closed containers on purpose-built trolleys with physical separation, and clean and dirty is identifiable. GENSA also goes a little bit further and says that they should be rigid, puncture resistant and easy to clean. Look at internal padding or brackets to make sure that the scopes are actually held into place as well. So maintaining a disinfected or sterile state of the flexible endoscope is directly tied to how well, not only is it processed, but it's also how it's packaged, stored, and of course transported. So looking at also in expiry control, and this is governed by both event-related and time-related sterility principles. So event-related sterility, endorsed by ST91 and ISO 15883-4, permits the use as long as the packaging remains intact and the storage environment remains validated. However, AS5369 and GENSA are still kind of recommending set policy-based shelf lives for within or outside drying cabinets. And this would be taking into account, of course, your own national standards and the organisation that determine these times. This also can be determined during operational qualification and or annual performance qualification. So all expiry dates and handling events must be logged as well, electronically or manually for traceability. And looking at how we manage our scopes, so kind of having a first in, first out system, also making sure that we validate our transport protocols, our sterile barrier integrity, clear expiry tracking, and the chain of accountability must be visible as well. Okay. So going into another one is the surveillance and the quality assurance of our scopes. So again, just to see what everybody's doing throughout there. So we're going to go to another poll, and it says, and so this one is, how often should microbiological surveillance of reprocessed endoscopes be conducted in high risk areas? So for ERCPs, duodenoscopes, bronchoscopes, like that. So monthly was winning by far, and now that after every procedure is starting to come up as well. So, all right, another few seconds. All right, so I'll end the poll there and share the results. So as you can see, monthly or defined by the facility risk assessment is at 55%, followed by after every procedure, which is at 33%. And then once a year an infection occurs is a little bit lower. So moving forward now into microsurveillance. So microsurveillance, it's an early warning system for endoscope reprocessing. It's not ensuring that, it's to ensure that we don't just assume that cleanliness, it's that we can prove it. And the guidance of these all the standards and guidelines all emphasize surveillance as a critical component of quality assurance. It's no longer just about ticking a box, it's more about detecting contamination risks before they impact patients. So the purpose is to kind of provide ongoing assessment of all your environment and equipment throughout the reprocessing workflow. It looks at practical applications where surveillance activities should target areas of equipment most vulnerable to contamination. And it includes post-cleaning residues or that can leave protein, microbial residue, and it also monitors the different types as well. And different kind of testing includes ATP tests, protein detection swabs, or of course our microbial culturing, especially when you're looking at validating new processes. Going into microtesting of endoscopes, so both the GENSA guidelines and ST91, they both acknowledge that microbial surveillance is a vital tool when verifying the effectiveness of flexible endoscopes. And however, their approaches differ slightly in the scope and the frequency. So GENSA recommends routine surveillance as a best practice, particularly after high-level disinfection, and is encouraging following repairs, changes in the equipment or chemicals, or, of course, when breaches are suspected. It's not mandated for every cycle, but it promotes a risk-based approach, where ST91 takes more of a perceptive stance, advocating for periodic micro-testing of endoscopes, and especially for critical scopes. And it kind of specifies the frequency and outlines action and thresholds that if the growth is detected, aligning with the CDC and the FDA recommendations. So in summary, GENSA kind of emphasises the surveillance as part of quality improvement, whereas ST91 has established it as a compliance measure with defined protocols, frequencies, and corrective actions. So what's new in this space? Well, I don't know if everyone's aware, but there is a new standard coming, and it's ISO 25224, which is a work in progress if you Google it and it comes up. So it's an international standard that's titled Sterilization of Healthcare Products, Sampling and Culturing for Reusable Thermoliable Flexible Endoscopes, which is a mouthful, but basically it's going to hopefully aimed at guiding facilities on how to micro-test culturing procedures to verify the cleanliness of flexible endoscopes, but it's also helping us establish evidence-based thresholds for contamination risk. So it will be part of enhancing our micro-surveillance as part of a broader QA program, and it also continues to support continuity across the globe practices as well. So going on to kind of what we polled about, but routine testing and the frequency. So as we know, routine testing is a critical part of endoscope reprocessing quality systems. It provides objective measurable data to confirm whether cleaning or disinfection processes are effective. And of course, standards and guidelines such as the ones we have and been speaking about all emphasize routine testing as a surveillance and assurance tool as well to make sure our processes are going well and working well. And there's, of course, several methods for routine testing like protein, soil residue test that are used to verify organic material. And then we have our micro swabbing and culturing of endoscope channels, valves, external surfaces. It also has stemmed to drying cabinets. So we look at doing micro testing of our drying cabinets as well. And so looking at testing, it's no longer a one-off task. It's kind of recommended that it's a structured schedule based on scope usage, and it should be part of your policies. It should be part of your QA. Routine interviews documented in the standards and guidelines suggest timeframes depending, of course, on device type and the patient risk profile, as we looked at in that poll as well. It's also about after post-maintenance and repair of endoscopes and AERs. It's kind of it's mandated that retesting after equipment services as well, and if you're updating to cleaning agents and major procedural changes, so kind of revalidating what the process is if there's big changes. Testing is not just about finding failure though. We don't want to find failure, but it's about confirming that the processes are working consistently and that staff competencies are being maintained. If we have a positive result sometimes, then it's also looking at to make sure that we can do some analysis on that. So even when results fail within acceptable ranges, a cluster of marginal positive can trigger a root cause analysis to prevent an outbreak or rectify before it becomes a bigger issue. So routine testing is kind of essential. It's not just for validation, but it's for continuous quality assurance. And if we look at integrating with standards and guidelines, the test kind of gives us confidence that our systems are working and it safeguards our patients. Kind of if you're not measuring it, you're not managing it. So it ensures that we're doing both in a measurable and a proactive way. So looking at some quality assurance systems in endoscopy. So quality assurance is also looking at that it's a system-wide commitment to safety and compliance and performance. Again, guided by standards and guidelines. It also helps us ensure compliance with accreditation and things like that. So QI systems ensure that every stage of the reprocessing is validated. And a daily process for verification is also kind of a frontline QA measure. So checking washer disinfector cycles, chemical concentrate verification, drying unit airflow testing, and even down to the leak scope, the scope leak tests, that all forms part of a QA. So kind of the aim is simple. Routine checks like these allow early detection of deviations and confirm the critical control points. And while failures of contamination events occur, QA or quality assurance demands more than that just we clean it up. Kind of states that we've got to do a root cause analysis. And an example of this is where a proactive quality assurance in practice occurred, and it's definitely at a hospital that I know, which is the one here. But during our routine microsurveillance of our flexible endoscopes, we had identified that we had a slight increase in positive results. Even though it was still within our acceptable thresholds, it was notable enough to trigger some kind of root cause analysis. So upon reviewing our processes, we decided to initiate some thorough cleaning and disinfection of our drying cabinets as a precautionary measure, or starting there. And of course, the affected endoscopes were quarantined, reprocessed under the controlled condition and stored appropriately. And luckily enough, following a second round of micro testing, all the scopes returned zero growth. And now that it's been a few months after that happened, our micro testing has gone back to having nil growth. So this just highlights the value of the surveillance of micro surveillance, but also the quality assurance in systems that are proactive tools, not just for responding to problems, but also identifying and mitigating risks before they actually compromise patient safety. So under the standards and guidelines, documentation isn't just a formality now, it's kind of legal, clinically, and it's a safety requirement. GENSA guidelines emphasise that every step of the reprocessing cycle must be traceable and verifiable. So this is to ensure, of course, patient safety and through the traceable records. It also provides defensible in the case of adverse events and supports accreditation and compliance audits. In the standards, they kind of also highlight the importance of life cycle documentation. So from receipt and usage to each cleaning, disinfection, drying and storage event, it can either be done manually or digital logs and can be used. Manual logs, can be used, but digital systems are actually reducing the risk of human error and, of course, improving accessibility. So why does good documentation matter? It's not just about ticking a box anymore. It's about ensuring accountability, as every operator is responsible for their documented actions. And through quick traceability of any reprocessed instrument that's linked to a patient can prevent escalation in the event of an outbreak or the risk of contamination. Also provides legal protection in litigation, and having documented proof of compliant processes can protect the facility and its staff. So kind of if it wasn't documented, it didn't happen. So the phase captures the mindset that's required for efficient quality assurance in high-risk world and endoscopy reprocessing. Documentation is not optional. It's a safety critical system, and it should be embedded in your practice as well as international best practice. Okay, going into our last topic, which is competency, documentation, and traceability. And we'll head to our last poll. So, how often should staff competency in endoscope reprocessing be formally assessed? So there's the poll, and it says once a day, once during onboarding only, every 5 years, annually or as defined by the facility policy and risk level, only after reprocessing incident.
David, I kindly ask you for moving more quickly
okay.
in this last part because we are trying to answer some questions, but
No problem.
the stage is yours. Sorry.
That's okay. Thank you. All right. So I'll end the poll as I've been wound up by Dr. Panos. Thank you. Sharing the results. So it's a no-brainer. 92% is saying annually or defined by the facility. So going into it, why is it critical? I'll speed it up. No matter how advanced our equipment is or the protocols are, the process is only as safe as the people performing it. So we need to ensure that our reprocessing staff have an understanding that errors in cleaning, disinfection, drying or storage can result in patient exposure to pathogens, and having competency ensures this consistency, safety and adherence to protocols. So there's formal education that form part of this. There's also site-specific training, which covers equipment, safe operating procedures, and of course, work health and safety. And then you've got your annual performance appraisals or through direct observation, quizzes and skill demonstrations. So something that come out of one of the guidelines was that competency equals knowledge plus skill plus consistency. So quickly talking about ongoing learning. So regular refresh and train to keep up with guidelines and updates, in-service sessions and external workshops. There are also learning platforms as well. So like from the WFHSS and of course the ASP Learning Lab. Looking at doing internal audits for compliance with protocols. It's not about it's not about finding errors. It's about identifying breaches that you can have where you can audit and do near misses, and it should trigger root cause analysis, but also encouraging staff to not a culture of blame, but a culture of reporting. And that's through learning about incident reviews and RCAs as well. Document essentials. So according to the standards, documents must include about verification records. You've got all your cleaning logs, sterilization records, any kind of biological indicator results. Also looking at equipment maintenance and calibration schedules. And also you've got your washer, sterilization, startup process logs as well. Daily checks are recommended, and this helps maintain daily operations as well, ensuring accuracy and compliance. And kind of looking at the drying cabinet pre-checks or pre-use checks are carried out as well, documenting parameters like temperature, detergent levels, filters, status, just some examples of what can be done. And then, of course, it comes down to legal and accreditation values. So clear documentation demonstrates compliance, protects the facility and staff during the audits and incidents as well. And finally, going into traceability systems. So traceability systems for me, or for what I think is the cornerstone of patient safety. It makes people more accountable, responsible, and if you can't trace it, you can't trust it, and you certainly can't defend it. So all 4 standards require comprehensive, traceable in endoscope reprocessing, and it ensures that every endoscope can be tracked from patient use to through to each reprocessing step and back into clinical surface. So part of the newer technology that's coming through as well, it talks about you've got RFID or barcoding that you can use now that some scopes have RFID tags embed. They're also can be attached, so that allows more traceability as well. And of course that they're looking at cloud-based, which you can actually enter into patient records, reprocessing steps, alerts for overdue storage, and so much more. There is some about mobile integration where staff can scan barcodes and get real-time logging and cycle verification, and then going into where QA logs, maintenance, micro testing and repairs are also being tracked per scope and ready available. So traceability is just a process. It's also a promise that each patient receives care with properly cleaned, disinfect and safe instruments. And by embedding kind of traceability across the reprocessing journey, we meet not only compliance requirements, but clinical and ethical obligations. So sorry I rushed that last bit, but these are just some take-home messages that I thought were important and that kind of stick in my head. So first one is, with the first topic, effective pre-cleaning and enhanced cleaning are essential for decontamination, ensuring patient safety by preventing biofilm, protecting equipment and supporting high-quality reprocessing workflows. Second one is thorough drying and proper storage of endoscope devices are crucial for preventing microbial survival, device damage and recontamination and ensuring patient safety. Third one is microbiological surveillance is a proactive quality assurance approach that ensures effective reprocessing and patient safety through routine monitoring and alignment with the evolving standards. And then lastly, skilled staff, precise records and full traceability ensures safe, compliant sterilisation services, ensures audit readiness and enabled fast response to incidents, protecting patients and healthcare workers. So, yeah, thank you very much. Back to you, Dr. Palos.
Thank you. First of all, I want to thank you for your extensive coverage of all the endoscopic reprocessing, because it is a complex one. It has a lot of steps, and sometimes some of the steps are somehow I wouldn't say forgotten, but sometimes not so considerate. So even which is absolutely needed, and also the transportation, the things about microbiological testing and all the traceability issues, and also, of course, the training of the healthcare personnel are essential, are crucial for assurance of the quality and the safety of these procedures. And sometimes, as the experience have shown us, we have from time to time problems, outbreaks related with use of endoscopes, not only duodenoscopes, which are of course the most important in terms of risk, but also other endoscopes. And you should all that in this should take a look at the references in order to complement your talk, because we could be here for the entire day talking on this with your enthusiasm. Thank you. The other thing I want to say is to apologize, because we had some technical issues in the beginning, and I hope that experience with the translation system has been a good one. So it is the first time that we are a company which is working with us. And all your feedback will be very important to understand the quality of all these new things. I have now a lot of questions, but I will ask you just two, and for the others, we will send you the answers through the systems when we are going to feedback you with the fact sheet and so on. So the first question is, how often should staff competency in the endoscope reprocessing be formally assessed? So it's a very important question because of the formally. Sometimes something are informal. So, for example, if you are in a process of accreditation, you lose the evidence that person, that team has been in fact having education.
Yeah, so this is a hard one, and it depends on your facility. But looking at, of course, if there is kind of a breach or a new process, then it would be formally assessed. Having some kind of fact sheet or something that goes with that new process, and then with the cleaning and because endoscopes are so complex, and I think the foundation is having an understanding of why we're doing it and what we're doing and the importance of doing it. I think that competency should be done probably more than what it's being done. I know definitely here, but there's no definite answer, and it would come down to standards. But I know with the standards and the guidelines we follow, our staff that are reprocessing have to do it regularly and have an annual base competency that's formally addressed.
Yeah. I think it's the question that most people answered, that it was annually done. And the second question is, what do you think about if low temperature sterilization using the hydrogen peroxide can replace ethylene oxide for all flexible endoscopes?
It's increasing, definitely increasing, as companies are now, and the manufacturers of scopes are moving forward. I know some of the newer ones that are coming out can go through low temp hydrogen peroxide, but it will increase. Currently, no, I don't think it can replace ethylene oxide for all flexible endoscopes. Looking at the manufacturer's IFU will hopefully show that, but it's definitely increasing, and I think it will become the popular or the most used sterilizing method in the future.
Yeah, it should be. And also, what about HLD? So, can you hear me? What about HLD? If it can in the near future, so what do you think about that?
So do you think, so the question is, will sterilizing replace HLD? Is that what you're asking, Dr. Carlos?
Yeah.
Yeah, I think HLD will always form a part. I think that it's a good part to have. For me and for what I see in the future, with the complexity of these devices, us not being able to visually inspect these lumens, I think HLD will go hand in hand with sterilization. So I think it'll form part. So it will be a HLD process followed by sterilization, and that just gives better assurance, better compliance, and patient safety overall. So for myself in my own facility, I sterilize our bronchoscopes and things like that after high-level disinfection. So I'm hoping it would increase and be incorporated with sterilization.
Yeah. So we have challenges on this, and we need to improve all the steps, starting with the cleaning, because without proper cleaning, we won't have adequate reprocessing. We hear some questions also about some very interesting questions about the new ways of, for example, cleaning. But as I told you, we are going to answer that on the directly with the attendees. So from my side, I just want to thank Mr. David Bellamy in Australia, and also to salute all the Australians that are in fact watching the webinar in live, and you are at night. So thank you very much. It was a huge pleasure to count on you, and a huge honor to have someone as important as you are. And thank you for your excellent talk. And I hand over to John to close this webinar. Thank you very much.
Thank you, Dr. Paulus, and thank you, everyone.
Thank you again, Carlos and Mr. Bellamy, for your insightful presentation. I'm positive it was very beneficial for our audience today. Thanks, Dr. Palos, also to moderate this webinar. So because we are running late, so just to let you know that next webinar will take place on June 26th, same time. Actually, we're going to have another session, but it's for North American LATAM that will be deployed at 5 p.m. Central Europe time. So if you are on Europe and you cannot make the first one, you have another option. So we're going to have the pleasure to have with us on June 26th, Mrs. Kari Ofsted, that will from Kari Ofsted and Associated Incorporation. So I think Kari does need presentations. Everybody knows her. So we will, as well as David, of course. So we will be having the webinar with her about the endoscope processing effectiveness, a reality check and call to action for clinicians and infection preventionists. So good thing she will publish this paper early next month, and she will be presenting at APIC national conference. So stay tuned. So as always, we're gonna have I will invite you to take a few minutes of your time to go through our survey. Okay, you're gonna receive it on the same email with all the assets. Make sure you just take and invest 2 minutes of your time just to let us know your experience, especially as Dr. Paulus mentioned about also what can we improve and what was your experience with the simultaneous translation. Finally, as I mentioned at the beginning, early next week, you're going to receive an email where you find not only your certificate, but also this webinar recording, the podcast, and the fact sheet with the key take-home messages and key highlights from this session. So please stay tuned to it, and we will add the questions, answers that we had no chance to respond today. So for us, thanks for attending and to participate today. I wish you all a lovely week, and I hope to see you all in the next webinar.